So the changes that I think are most relevant to people in practice are, number one, in HER2-directed therapy in patients that have operable breast cancer, we now allow for the use of dual targeting of the HER2 pathway. And our guidelines are based on, our recommendations are based on data from the so-called Neosphere trial that showed that you could increase the fraction of patients achieving a complete resolution of disease in the breast by using both pertuzumab and trastuzumab along with chemotherapy. And by itself that wouldn't be all that meaningful, but we're starting to see evidence, perhaps, that translates into a better outcome overall. So just achieving a PCR, that sounds good, but unless it improves the patient's overall outcome, it's just a number. So we now have some data suggesting that indeed does translate. And we make that recommendation because we had evidence in the metastatic disease setting that this is a highly effective regimen. We have the Neosphere trial preoperatively showing it's effective, and we have a completed adjuvant trial called the Affinity trial. And all of those things come together that allow us to make that recommendation. The other area that I think is relevant is in hormone receptor positive disease in those patients with metastatic disease. We've seen the evolution of the guidelines change so that instead of simply recommending endocrine or anti-hormonal therapy by itself, we now frequently partner it with targeted therapies like everolimus or palbociclib. And those recommendations are based on clinical trials that showed a significant improvement in outcome when you do that. It changes the nature of endocrine therapy a little bit. When you add targeted therapy, you buy a bit more in the way of side effects, but it has also translated into a marked improvement in progression-free survival.